So good afternoon. This workshop covers universal screening to identify perinatal hepatitis C virus infections and an opportunity for timely diagnosis and management. So we're excited everyone's here. I'll let Dr. Morad introduce our first speaker.
Excellent. So I'm going to introduce Dr. Jimmy Carlucci. I've known Jimmy since he was in training, so we're super excited to have him back. He's the assistant professor in the Division of Pediatric Infectious Diseases and Global Health at Indiana University School of Medicine. His research is primarily focused on improving retention of HIV-exposed infants and prevention of mother-to-child transmission services in sub-Saharan Africa. That said, many similarities between the HIV-exposed infant continuum of care in Africa and the pediatric services that are recommended for hepatitis C exposed infants in the United States. Therefore, he's taken a clinical, quality improvement, and research interest in this group of patients. So I'm going to turn it over to Jimmy to talk to us some about HCV-exposed infants. Oh, Amanda reminds me really quick, Jimmy, before you get started, check out the podcast. He did an amazing podcast on this.
Well, thanks for the introduction. I am currently at Indiana University School of Medicine. I joined the team here in July, but I have to say that I have to give credit to Vanderbilt and folks at the Tennessee Department of Health and Tennessee generally for really growing me up. As Dr. Morad mentioned, I really did all of my training at Vanderbilt Medical School. Medicine and pediatrics residencies, and my subspecialty training in pediatric infectious diseases at Vanderbilt. And until recently, I lived in Tennessee. So I'm really grateful to be participating in the annual TIP-QC meeting. Go ahead and go to the next slide. And I have no disclosures. You can go to the next slide. So the overview of what I'll be talking about over the next 30 minutes or so is first to start with talking about hepatitis C generally. So I'll talk about risk factors, the natural history of hepatitis C infections, and the epidemiology both globally and locally in Tennessee. I'm going to talk about hepatitis C screening during pregnancy, looking at both risk factor-based screening approaches, which is kind of the historical approach, and universal screening approaches, which is hopefully the direction we're moving. I'm going to share some cost effectiveness information about universal screening in pregnancy, and then I'll update you on CDC, the U.S. Preventive Services Task Force, and ACOG recommendations as they pertain to HCV screening, and then I'll talk some about postpartum management of Hep C affected moms and babies. And I've been told that the most effective presentations are those that tell you what the key messages are right up front, go through the presentation, and then give those messages, and then at the end summarize those messages. So I'm going to tell you right up front, if you take nothing else away from this, there are a few important things. One is hepatitis C is common, and it's a disease that can have a lot of morbidity and mortality associated with it. It affects young people, including young women, and potentially their newborn babies. And I want to tell you that as it stands currently, there are a lot of missed opportunities for diagnosing and treating those moms and babies. But hopefully with implementation of universal screening, we can overcome some of those shortfalls. So that's the takeaway. In terms of risk factors, I should first tell you that hepatitis C is the most common bloodborne pathogen in the United States. Risk groups include baby boomers, those with current or prior injection or inhaled drug use, those who have unregulated tattoo or piercings, those who've received blood products or clotting factors prior to 1992, when it became standard to screen blood products for hepatitis C. People with HIV are at higher risk for hepatitis C, those who have potential for occupational exposures, those who have unprotected sex, and people immigrating from regions of the world where hepatitis C prevalence is quite high. All of those are potential risk factors. And then for children, the primary risk factor is being born to a mother who has active hepatitis C. Next slide. So in terms of vertical transmission or mother-to-child transmission, it's estimated that about 5% of babies born to moms who have active hepatitis C will go on to have hepatitis C themselves, and that risk is probably doubled in pregnancies that are complicated by both hepatitis C and HIV co-infections. And that's probably also the case for women who have other immunocompromising conditions. And so risk factors for vertical transmission are higher viral loads, prolonged rupture of membranes, invasive monitoring, so like using scalp probes, for example. You go to the next slide. So Hep C comes in a couple different flavors. You can have acute or chronic infections. So acute infections can range from asymptomatic infection to fulminant hepatitis, so a broad spectrum of potential clinical manifestations. And then among those who have acute infections, a subset will go on to have chronic infections, which are defined as having Hep C detectable for 6 months or more. Interestingly, there's an inverse relationship between age and the risk of going on to have chronic infection. So for infants, for example, those who have perinatally acquired hepatitis C, there's about a 20–30% chance that they'll just clear that infection on their own. Or put differently, 3/4 of those babies will go on to have chronic infection. Whereas in adults, if you're acutely infected with hepatitis C, it's more of a coin flip, maybe 50-50 that you'll spontaneously clear the infection versus going on to have a chronic infection. Next slide. And then among those who are chronically infected, there's really an insidious progression of disease. It starts with inflammation in the liver, leading to hepatocyte necrosis, ultimately fibrosis, and then when fibrosis is widespread, a person has cirrhosis. So it's about 1/4 of people with chronic Hep C who go on to have cirrhosis, and that develops over a period of 20 to 30 years in most cases. And ultimately, that can manifest as end-stage liver disease. These folks are at higher risk for hepatocellular carcinomas, and they can die. Next slide. So I've just told you that hepatitis C is a potentially serious disease, but how common is it? So in terms of the epidemiology, first starting globally and then getting a little more granular, it's definitely a leading cause of liver disease in both adults and children globally. It's estimated that about 185 million people are Hep C infected worldwide. So that translates to about 2.5% of the global population. But there is a lot of regional variability. So the highest prevalence is seen in parts of northeastern Africa. So like in Egypt, for example, the prevalence is approximately 10%. Whereas in the United States and many other higher resourced countries, prevalence is usually closer to around 1%. Next slide. So looking at the United States, it's estimated that about 2.5 million people in the US are living with hepatitis C, which translates into about 1% of the adult population. But interestingly, only about half of those people are aware of their Hep C status. And again, there's variability from state to state. So in Tennessee, it's estimated that about 1.5% of folks have hepatitis C, which is about 50% higher than the national average. Next slide. And then getting even more granular, looking at pregnant women specifically, and looking at pregnant women in different counties within Tennessee, the prevalence ranges from about 2.5% to 8% in some counties, which is really, really striking when you think about the number of pregnant women that come through any given health facility. This, as the map implies, is more concentrated in the eastern part of the state. And if you were to look at the contiguous states, like you can see in the map, the United States map to the left, this really is affecting the Appalachian range more specifically. So risk factors include being a single woman, living in a rural area, having less education, and being white. And so where these things sort of overlap is in the Appalachian area. And this strongly correlates with the opioid epidemic and injection drug use. Next slide. So this figure is showing incidence on the y-axis and time on the x-axis. The green line is the United States and the sort of brown line is Tennessee. And you can see that the incidence has gone up in recent years in the United States generally, but in Tennessee, it's kind of doubled the national average. Next slide. And as it turns out, most of these new infections, so when we're talking about incidence, we're talking about new infections, are among young people. And it seems that this is being driven by the opioid epidemic. So again, in the Appalachian population, there's been a 364% increase in acute Hep C infections, and more than half of those are attributable to IV drug use. Next slide. So this figure is a little busier, but shows more or less the same thing. Y-axis is incidence, x-axis is time. And then I'll just direct you to a couple of the lines, the colored lines, which represent age groups. So the purple line are 20 to 30-year-olds, and the yellow line is 30 to 40-year-olds. And you can see that in recent years, the new infections in those age groups has been increasing. Next slide. And interestingly, this has resulted in now a bimodal distribution of Hep C cases. So it used to be that there was just sort of a single peak, and that usually corresponded to the baby boomer age groups. But now, not only are there those baby boomers, but then there's also another peak in younger age groups. This is showing data both from California and New York, so both coasts. And if you go to the next slide, you'll see that we see the exact same thing in Tennessee. And why this is concerning, or at least part of why this is concerning, is it's sort of traditionally thought that among the baby boomers, these are not cases that should be neglected, but it tends to be a more stable population in terms of transmission to others. Whereas in this young group, we're talking about young people who are sexually active, potentially having children and exposing those children, and then also engaging in high-risk activities like drug use. So not only is there this new peak, but it's a peak that has the potential to grow out of proportion to what we've seen with the prior peak in baby boomers. Next slide. Okay, so how do you screen for and diagnose hepatitis C? Really, there are two tests you should know about. There's Hep C antibody tests or anti-HCV tests, and there's Hep C RNA PCRs or viral loads. The antibody test is an indirect way of looking for Hep C infection, which may be recent or it may be years ago. All it tells you is, has a person's immune system seen hepatitis C at some point in the past? It does not tell you whether or not they have active infection. Whereas the RNA PCR is more of a direct test. It's looking for nucleic acids from the virus itself. And so if your Hep C RNA PCR is positive, you have Hep C in your body at that time. So how do you interpret test results? You mind going back to the other slide briefly? So how do you interpret these test results? So if a person has a negative anti-HCV test, so a negative antibody test, and they've not been exposed, and in that scenario, you probably wouldn't get an RNA PCR, but if you did, it presumably would be negative. So they've never been exposed and they don't have active infection. If the anti-Hep C antibody is positive, then it should reflex to the RNA PCR. And if the RNA PCR is positive, then the person has active infection. If it's negative, then the person does not have active infection. So that might be a scenario where a person either had an acute infection in the past and spontaneously cleared it, or maybe this is someone who's benefited from Hep C treatment and now has cleared the virus. Next slide. So to put that into more of an algorithmic approach, how do you diagnose a person? Well, you should start with an antibody test. And if it's negative, so going down the left side of that pathway, then you're done. The person's not been exposed, and presumably they don't have infection. The only caveat there is if you're worried about a very acute recent infection, there's a window period where they might not yet have made antibody. And so those are people who should have repeat testing at some point down the line. If your antibody test is positive, then again, you should reflex to doing the RNA PCR. If the RNA PCR is negative, then that person does not have active infection. They had prior infections they've cleared or they've been effectively treated. But if the RNA PCR is positive, then those are people who have active infection who need to be linked to care. Next slide. Okay, shifting gears a little bit to thinking about screening during pregnancy. So again, the historical approach has been risk factor-based screening. So identifying people who have a history of IV drug use, for example, and making sure they get a hepatitis C test versus universal screening where everybody gets tested regardless of risk factors. There are pros and cons to both. I've already revealed my bias, but I think universal screening is the way we should go. And the data, I think, supports that opinion. And I'll tell you more about that as we go. But for the sake of building that argument, I'll first tell you kind of pros and cons to both. So the downsides to risk factor-based screening are one, it's dependent on the person recognizing and reporting that that risk factor. So there's potential for recall bias. There's potentially stigma and risk of disclosing things that a person might not want to disclose to their provider or anyone else. And so there's a person may be aware of a risk factor, but they might not report it. So reporting bias. And then it's provider dependent. So if the provider doesn't ask about whether the person has risk factors, they're unlikely to just volunteer that information. The pros is that, at least in the short term, it's more resource efficient. You're only testing those who are at highest risk, right? So now looking at universal screening, there are also pros and cons. So the cons, which I would argue are based on false premises, but I'll tell you them anyway. The cons are that some people might say, well, the results aren't actionable during pregnancy. Yes, I can diagnose a woman with hepatitis C, but if treatments aren't approved for use during pregnancy, what am I going to do with that information? Again, I think that's not a great argument because quite simply, you could refer the person for care postpartum. That's something you can do. You can make sure their baby gets engaged in care. You can make sure that other potentially positive people get referred for testing. So their partners, their other children, for example. Another potential con to universal screening is that it's more expensive. If you're testing more people, that costs more money, right? But again, I think that's a little bit short-sighted. If you look at long-term and sort of skipping down to the pros, if you look at it from a long-term perspective, it really is probably more resource efficient. Because while on the upfront, you may be spending more on cheap antibody screening tests, in the long run, you're going to be saving money by not having to treat people who have advanced liver disease, which, you can imagine the cost of a transplant, a liver transplant, and all the lifelong care that goes along with that, or the life's lost and the potential, economic consequences of that, compared to the cost of a cheap screening test. And then the other pros, of course, are that it's patient and provider independent. You're not dependent on the patient reporting a risk factor. You're not dependent on the provider asking about those risk factors. And in that sense, it's more sensitive. You're less likely to miss people. Next slide. But you don't have to take my word for it. So there have been studies that have looked at risk factor-based screening, and pretty consistently, it's less reliable than universal screening in terms of identifying cases. So this is just one example, a study out of University of Maryland where they looked at 1,400 pregnancies. 100 of these women were screened for hepatitis C, and 10 of those 100 who were screened were positive. So 10% positivity among a group with identifiable risk factors, and which translates into about 1% of the overall cohort. But when you looked at those who had identifiable risk factors, only 64% were actually screened. So, of those who weren't screened despite having an identifiable risk factor, so those 50, if you were to extrapolate a 10% prevalence among people with risk factors, that's 5 missed cases, when on a risk factor-based screening basis, you only caught 10. So by doing universal screening, you sort of increase your yield by 50%, is one way of looking at this data. Next slide. And that's not unique to Maryland. This is data from Vanderbilt, and it's looking at outcomes within a cohort of opioid-exposed moms and babies. So these are all opioid-exposed women, so all of them have risk factors. And we found that 18% of those women with known risk factors weren't tested for Hep C prior to delivering their babies. Of those who were tested, 30% were positive. And of those, and so again, if you extrapolate 30% positivity rates to those who weren't tested but should have been tested, that translates to as many as 14 misdiagnoses. Next slide. And in terms of cost effectiveness, I won't get into the weeds of the analyses that go into a cost effectiveness assessment. It's kind of statistically nuanced, but what I will tell you is how to interpret an ICER. So the ICER, which you see in the parenthetical next to the section that I've highlighted from this abstract, is the incremental cost effectiveness ratio. And so basically it's like, how much money do you spend per quality adjusted life year? And in general, within the cost effectiveness analysis community, an ICER less than $25,000 is typically considered cost effective. And when I talked to one of my colleagues who does this type of research, and I shared this report with him, he was like shocked that this was even a debate. An ICER of less than 3,000 is like a no-brainer that it's cost effective to universally screen these women. Next slide. And the same group did another analysis looking at rescreening. So if women tested negative during a past pregnancy, what's the cost effectiveness of screening them again in subsequent pregnancies? And it was still cost effective in that scenario with an ICER of about 6,000. Next slide. So to summarize, what are the benefits of testing, universal testing during pregnancy? One is that it more accurately defines the population at risk. So both the women who are affected and potentially their exposed infants. It seizes an opportunity for testing when women are more intensely engaged in the health system than maybe they'll ever be at any point in the rest of their lives. It improves pregnancy and peripartum planning. So getting back to that argument of certainly there are things you can do during the pregnancy with this information. It might inform whether or not you use invasive procedures like using a scalp electrode. Something like that, can increase risk for vertical transmission. Moms can be referred for postpartum treatment. And as Dr. Morad pointed out in the podcast that we referred to at the beginning of the presentation, for some of these women who otherwise don't have health insurance, but have it peri-pregnancy, getting them referred to care and treatment while they still have that insurance is potentially, really time-sensitive thing to do. And also reduces risks for future pregnancy. So if you get a mom treated in the postpartum period, and then potentially you prevent having to go through all this again with subsequent pregnancies. And then it also ensures that their babies are referred for appropriate postpartum management. And like I mentioned before, it also offers opportunity to identify other at-risk individuals. So the woman's partner, their other children, for example. Next slide. So how do CDC and USPSTF feel about this? They share my opinion, or I should say I share their opinion. Their recommendations as of 2020 are that all pregnant women should be screened for hepatitis C with every pregnancy, period. And I should say that they also say that all adults 18 and older should be screened for hepatitis C at least once. So even if you're not a pregnant woman, you should get a hep C test. It's that common that it's sensible for us to do this. Next slide. So ACOG has not yet endorsed this recommendation. The last sort of update I saw from ACOG was from April of 2020, so about a year ago. And at that point, they were actively reviewing the CDC and USPSTF guidance. I'm hopeful that they will adopt a similar stance and disseminate that soon, because I do think that their endorsement will carry a lot of weight and hopefully move us towards universal screening nationwide. Next slide. So what are the treatment options for moms and babies? Before I tell you too much about that, I think it's important to kind of contextualize how far this, how much progress we've made in this space over recent years. So in the era before direct-acting antivirals, we were using interferon, ribavirin, medications that were really had a lot of toxicities, were not very well tolerated, and had cure rates that were less than 50%. Now, in recent years, with the direct-acting antivirals, we have 95% plus cure rates. We can treat essentially all genotypes of hepatitis C. Some drugs are pan-genotypic. They have very little side effects, and for the most part, they're one pill, once a day regimens for 3 months, and a person is cured. Next slide. And that's basically what I say here. I'm not going to get into the specifics of which drug and which scenario. I think that's beyond the scope of this this talk. But again, the point is that the medications that are now available are very well tolerated. Cure rates are very high, and they're now approved down to 3 years of age. Oh, and I should say that I didn't put that on this slide, but recommendations are now to treat basically everybody who's Hep C positive, period. Where before, it was dependent on like your fibrosis stage, things like that. Now, pretty much anybody who is Hep C, who has chronic hepatitis C is treatment eligible. Next slide. Getting back to some of that data from Vanderbilt, I showed you previously that there were some missed opportunities for diagnosing women with known risk factors. But even among those who were positive, so among those who tested positive, there were still some gaps in referrals. So 75% of those women who were identified as Hep C positive during pregnancy had no documentation of a referral postpartum. So a big gap in the treatment cascade there. Next slide. Okay, shifting gears a little bit to the Hep C exposed infants. So what can and should we be doing for them? So the historical gold standard has been to do an antibody test after 18 months of age. 18 months is sort of that magical cutoff that we use where we feel pretty confident that there's no longer going to be circulating maternal antibodies in the baby. So an antibody test in the baby can be reliably interpreted. But we also have RNA PCR tests available. And so a lot of experts, myself included, have moved towards doing earlier testing with PCR-based tests, which can be done as early as 2 months of age. And I recommend doing that if for no other reason to seize the opportunity while it's there. Because as we know, there are a lot of social determinants that affect these mom-baby dyads, and loss to follow-up or sustained engagement in care, but differently is not always a guarantee. Next slide. And this is a study from Susan Lapata, who's a neonatologist at Vanderbilt. And it basically gets at that point that I just made. So among Hep C exposed infants in Tennessee, this was a statewide analysis. Only 1 in 4 were tested, and only 1 in 5 were adequately tested. So they got the right test within the right sort of time frame in terms of their age. Next slide. And she also identified in this analysis that there's some disparities. So African Americans were only 1 in 10 HCV exposed African American got Hep C testing. Next slide. And then coming back to the opioid-exposed cohort at Vanderbilt, this is the opioid-exposed newborn side of the cascade. So before I was showing you the moms, but for the babies, there are also some gaps in care. So of 241 opioid-exposed newborns, a third of them were identified as being Hep C exposed. So that was the 77 moms who were Hep C positive. Those babies are therefore Hep C exposed. Of those who were exposed, we do a pretty good job of making referrals for care, but whether those referrals result in an actual appointment being scheduled was not perfect. 18% did not have a HCV referral scheduled. 27% did not attend their appointment. So getting at that loss to follow-up issue I pointed out a moment ago. And then altogether, only about half received what I would consider optimal care through 2 months of age. So definitely some work that needs to be done there as well. Next slide. Okay, so to summarize, Hep C, if undiagnosed and untreated, can lead to severe liver disease, potentially death. It's common among young women, and therefore among newborns as well. Universal Hep C testing during pregnancy is superior to risk factor-based strategies, and it's recommended by both the CDC and the USPSTF, and hopefully ACOG soon. Otherwise, healthy women and children with Hep C can be cured with direct-acting antivirals. And as it stands, there are currently gaps in the mother-infant Hep C cascade of care that need to be mitigated to ensure both optimal maternal and infant outcomes. And again, if we're to implement universal screening, I think we'll come to see that we're only currently seeing the tip of the iceberg. So I'll stop there. Happy to take any questions.
Thank you, Jimmy. I think we're going to ask, if you don't mind, to hold on, and we're going to have Lindsey present, and then hopefully both of you can take some time to answer questions at the end of the workshop, if that sounds good.
Absolutely. Sounds good.
Wonderful. Well, next up, I am happy to introduce Lindsey Sizemore. Lindsey is the director of the Viral Hepatitis Program at Tennessee Department of Health. She also serves as the project lead for both the Governor's Association for Best Practices on state strategies to address infectious diseases related to substance use and the HHS Hepatitis C Medicaid Affinity Group. I apologize, I can't speak this afternoon. She serves on the chronic HCV team as the team lead in the development of the CDC viral hepatitis surveillance guidance and was a co-author of the CDC document detailing surveillance efforts around HIV and hepatitis C outbreaks. In addition to all these duties, she also co-leads the COVID-19 and Pregnancy Project and served as a subject matter expert for CDC on behalf of jurisdictions developing similar projects. Lindsey is going to talk to us about the Tennessee efforts around hepatitis C. Thank you. Lindsey, I'll turn it over to you.
Great, thank you so much. Can you hear me?
We can.
Awesome. Hi, everyone. So as mentioned, I'm Lindsey Sizemore, and I'm really excited today to provide you with a brief overview of our efforts as they relate to identification, education, and linkage to care for mothers with hepatitis C and their babies. Next slide. So on January 1st of 2018, the Tennessee Department of Health Viral Hepatitis Program began conducting prospective surveillance on hepatitis C positive pregnant females and exposed infants. And we really wanted to track perinatal hepatitis C exposures and evaluate testing outcomes among hepatitis C exposed infants. Next slide. So Tennessee has had over 20,000 newly reported cases of chronic hepatitis C each year since 2016, which is when we actually began surveillance for chronic hepatitis C. And as Dr. Carlucci mentioned, we see a clear bimodal distribution among baby boomers and reproductive aged adults. But the 2018 perinatal hepatitis C exposure data is depicted here. And in 2018, there were almost 1,400 infants perinatally exposed to hepatitis C statewide. However, we know that issues with both testing and reporting exist, and that this number is likely much higher. Next slide. And further, we know that based on our 2018 surveillance data, infants perinatally exposed to hepatitis C are concentrated in Eastern Tennessee, and that testing of infants remains a significant issue. Next slide. We also know per an analysis we conducted in 2019 that there is overlap among a maternal history of hepatitis C infection and an infant NAS diagnosis. There were 80,755 live births in Tennessee in 2016, and of these infants, 1,227 had an NAS diagnosis within 1 year of birth, and 1,614 were born to a mother with a history of hepatitis C infection. When examining the overlap, we found that more than 1/3 of infants diagnosed with NAS were born to a mother with a history of hepatitis C infection, and that most of these infants resided in Eastern Tennessee. The significant overlap suggests that hepatitis C testing among women of childbearing age can serve as a proxy for drug use, as we've heard several times over the last few days, and that the benefits of identifying hepatitis C infection among women of childbearing age can include linking hepatitis C positive women to treatment for hep C, as well as to family planning and harm reduction resources, including mental health, opioid use disorder treatment, syringe services programs, and other supportive services. Next slide. So recognizing that we needed to use our surveillance data for action in terms of ensuring appropriate infant testing for hep C, linking the mother to treatment and wraparound services, and determining the perinatal hepatitis C transmission, not exposure, rate in Tennessee, the perinatal hepatitis C coordinator position was created. Next slide. So based on the surveillance data I just reviewed, it should come as no surprise that we chose Knoxville and the 15 surrounding counties as our catchment area to initiate our perinatal hepatitis C data to action efforts. Next slide. So our data to action efforts have a two-pronged approach. The first is navigation of mothers and infants to ensure we have someone prioritizing this highly vulnerable and highly stigmatized population. And the second is chart abstraction, as perinatal transmission of hepatitis C is still not well understood, as well as provider education on hepatitis C testing recommendations and interpretation of results for both adults and children. Next slide. So this is Laura Price, our perinatal hepatitis C coordinator, who conducts the navigation of hepatitis C positive mothers with a recent live birth and their infants. And I've asked Laura to share some of her personal experiences and takeaways from her navigation efforts, which I think you will find interesting but not surprising. And so as you can see here, Laura says, many women report substance misuse as their risk factor for hepatitis C. Some women do not want to discuss risk factors at all. Others are very open and want to share their story with me, but that these are typically the women who are on a pathway to recovery, either on their own or through a program. Next slide. So Laura also says that some women have confided in me that they face judgments from the office staff at their doctor or child's pediatrician, and that this can be a look or whispering, and this deters them from being open about their hepatitis C positive status with their provider. Most of the women that she has spoken to report that they suffer from depression or anxiety, and most are on prescription medications. But some good news is that she has noticed an uptick in the last 6 months of women who have started hepatitis C treatment prior to her phone call. Next slide. Laura also reports, so as Dr. Carlucci mentioned, you can do the RNA testing as early as 2 months, but that pediatricians report to Laura that they plan to test for hepatitis C antibody when the child is 18 months of age, despite some mothers wanting their child to be tested for hepatitis C RNA sooner. Some providers are unaware of the Tennessee Department of Health reporting requirements, which could be hindering our identification of mothers to navigate, as well as impacting our ability to see the complete picture as it relates to testing of infants for hepatitis C. And given that sometimes these infants are not in the custody of the birth mother, the Tennessee Department of Children's Services is a very supportive community partner. Next slide. Okay, and this is Cynthia Brooks, who conducts the chart abstraction and provider education efforts. And so I asked the same of Cynthia to tell me what she notices from her day-to-day work. And so Cynthia reports that many of the newborns were diagnosed with NAS. And so that got us thinking, okay, what does this look like in our sample, right? And so of the 155 infants in our sample with NAS information reported, about 40% had an NAS diagnosis. And then Cynthia also reports that she's had some challenges in obtaining requested documents, and that sometimes she has to make multiple requests to get the needed information. Next slide. Cynthia also reports that, similar to what Laura stated, most providers are documenting that they're going to test the infant for hepatitis C antibody once the child is 18 months of age, and that when calling providers, she finds that many are unaware of the infant hepatitis C testing guidelines, and so she takes that as an opportunity to educate them at that time. Next slide. Okay, and so I wanted to end by letting you know that we're planning to do a substantial amount of education over the next few weeks, and that we're trying to coordinate with as many partners as possible to have them share the available resources. And so I'm going to quickly show you what these look like on the next few slides. And so what you can see here is a CDC developed 2-pager that provides general information about hepatitis C. Next slide. And this is also a CDC developed document that provides a nice summary of the updated hepatitis C testing recommendations that Dr. Carlucci mentioned, which were released in April of 2020 and include testing all adults 1 time, as well as pregnant women in every pregnancy. Next slide. So the top link on this slide contains information on required reporting to the Tennessee Department of Health, and the middle and bottom links include information on learning to treat hepatitis C virus through a Tennessee-based training center. And spoiler alert, that's Vanderbilt. Next slide. And so for printable copies of the hepatitis C and pregnant women brochure that we developed and is available in English, Spanish, and Arabic, please email Laura Price, and you can find her email here, but it's laura.price@tn.gov. Next slide. And for printable copies of the infant hepatitis C testing recommendations one-pager, which was also developed by us, and we mail this to mothers that Laura navigates for the mother to take it to the infant's pediatrician. And so this one-pager outlines testing recommendations for children born to a hepatitis C positive mother, as well as some frequently asked questions as it relates to infant hepatitis C testing, vertical transmission of Hep C, and reporting requirements to the Tennessee Department of Health. And so you can also email Laura to obtain a copy of this one-pager. Okay, and so I wanted to end this presentation by thanking Laura, Cynthia, and Heather Wingate, who is our amazing epidemiologist, for all of their hard work each day on these important efforts. And I realized that was a lot of information packed into 10 minutes. And so if you have any questions, please feel free to reach out to us. Our emails are listed here. And because this information sometimes feels very heavy, I wanted to end on a happy note. This is my daughter, Charlie, and our puppy, Lola. And this is why I'm so passionate about the work that I do. So thank you, everyone.
Thank you so much, Lindsey. That was a great presentation. I think we'll go to questions now. And I think both of you brought up the point about the earlier testing and how some of these babies will not be in their biological mother's custody later on. And I can say I saw a 13-year-old in clinic who had the first testing, and I was surprised that it went back that far. She had the RNA testing at 1 to 2 months. I think it was actually 2 months through our system, and then had changed custody before the repeat testing. And so never had repeat testing, which is interesting because I honestly did not realize that the RNA testing started back that long ago. And we still have yet to pick it up as consistent practice. So let's see. I think Lauren had a question in the chat that Jimmy answered. And her question was, if mom is co-infected with HIV but has an undetectable viral load, is risk of transmission still 10%? And Jimmy said, short answer is probably not. Mom's well-controlled HIV likely will have better control of HCV and less placental inflammation. So the risk for transmission could be lower. What other questions do we have? Are we able to unmute microphones, Patti?
I am not sure about that. Amanda, do you know if we can unmute everyone's microphone?
We can, I think. Let me test it on Brenda. She's here.
While you test that out, I might just editorialize a little bit about the issue of primary care doctors wanting to wait until 18 months. I think it's like we shouldn't be shaming folks into like, oh my God, you're waiting until 18 months to test these kids. Like, I don't think that's the point. Yes, there are opportunities to test sooner, but if you as the primary care doctor have a great relationship with a family and feel confident that you're going to have this mom and baby engaged in care, for years, is it wrong to test at 18 months? No, that's the historical gold standard, and that will still get you to the right place. I think the point is the one that Dr. Morad pointed out, is that for a lot of these moms and babies, that's just not the reality. A lot of these kids, because of substance use during pregnancy, are in foster care. The foster parents often don't know about the exposure. There's a referral set up before they even go home with the foster parent. They may end up with a different family than the one that they're with at the time of discharge from the hospital. There's just lots of unpredictability. And so I think the point is, seize the opportunity early if possible. What's the downside of that? A PCR is a little more expensive. Positive PCR at 2 months doesn't necessarily mean the baby won't clear it 2 months later. There's 20-30% chance that might happen. And so repeat testing to confirm a positive test is important. But again, like I think, providers, often know their patients and know them well. And if there's a scenario where they feel confident that they can do it at 18 months, that's not wrong. I think the point is just that, often when we think that we if we just like stick into our old practice and don't think about some of this nuance, then we might miss some opportunities.
That's a great point.
This is Brenda. I'm supposed to talk to see if you can hear me, and I'm guessing you can. Thank you so much, Jimmy and Lindsey. And my question that I chatted in was, you know, are we at the point as a QI organization that TIPQC is, are we at the point that this might be a QI project? Are we ready to implement? You know, what's your suggestion there? And
everybody talk at once. So do you want to talk a little bit about the cost burden for the Hep C testing during the prenatal panel? Lindsey, do you have any thoughts on that?
I'm sorry, the cost barrier.
Right, the cost barrier. Do you have it? I mean, I think that's probably where we're meeting some resistance. It's just the cost of the prenatal, adding it to the prenatal panel.
Yeah, I think that's part of it. I did have Laura get added as a panelist just because she is the one that's actually, you know, talking to these mothers day in and day out. And I wanted to see if Laura has anything to add. But I will say that it does seem, I think that is the barrier for sure. And that's kind of some of the resistance, for lack of a better word. But I also think we have to look at the whole situation too, right? Which is the mom wants the infant to be tested. The mom wants to know. And I think about, and I tell the story all the time, but when my daughter was born, I mean, everything went wonderful. Everything was great. You know, she was breastfeeding. I mean, truly like perfect child, right? And she would just cry all day long, all day long. And I remember calling the pediatrician just beside myself. And I'm like, okay, I know I've been a mom for like 2 weeks, right? But like, I know this baby. I know this baby and something's wrong. And I just think all the time about, you know, we have women out there who have had babies, right? Who may have hepatitis C. They may not know that's even a possibility, right? Because they may not be even aware of their status. Or, you know, here they are, we have some of them out there trying to advocate. I want my baby to be tested. I want to know my baby's status. I want to know what, you know, what my baby has and what we're going to maybe be dealing with. And that, you know, the provider saying, well, we're going to wait. And so, you know, just, I think as a mother, that, I don't know, I would just be really, that wouldn't feel very good, right? Because you want to know, and you want to know what's going on with your baby. But Laura, are you able to unmute and weigh in on that question?
About the moms wanting testing?
Yes.
Yeah.
But also some of the barriers that you think as to why, you know, the providers are waiting.
I think probably what's happening is that standard practice, and sometimes I think it's hard to change those ingrained habits. Can you hear me?
Yes.
Yes.
Okay. I think that might be the primary reason, is just getting the information out, even to the providers, about the new testing recommendations and what's available. And then just getting the moms to be heard. You know, we're hearing a lot about that during this conference, even. To make sure your voice is heard. So I'm not sure always that, you know, you're allotted only like 15 minutes, you know, for your appointment. So it's hard sometimes to get that information out there and what the mom may really want as far as testing.
So back to Brenda's original question, I guess, is this a workable QI project for the entire state?
Can I ask you to clarify, are you asking universal screening in pregnancy or ensuring that babies get HCV exposed babies get screened according to sort of newer guidance?
Yeah, I think we have to have universal screening of moms during pregnancy because if we don't know the mom status, then you are going to miss babies every time, right?
Right.
I mean, I definitely think that both are a workable project right now, especially, you know, the testing guidelines, which I feel like we've all been working towards and, you know, really passionate about for a long time, came out at like the worst possible time ever, right? Because it was right when COVID was hitting. And so, you know, I feel like had COVID not happened, we would have done a lot of blast education and, you know, just a ton of outreach. And potentially try to even explore getting screening and pregnancy added, like what we do for HIV and syphilis and hepatitis B, right? But just with COVID, we couldn't. And so I do think that both of those are workable projects, and that can we please follow up offline and make sure that happens?
Lindsay, in the group, it's Laura again. I just want to mention too, just some comments from some moms. I think sometimes they are so uncomfortable bringing up the fact to the pediatrician that they have hepatitis C. They talk about the looks they get, or they can see side conversations that staff members are having. So it makes them feel bad about themselves, like they're less than. And so that is a difficult hurdle to get over as well. So I think we have to be mindful of that too, that even though some moms may know their status, they're not always sharing that with the provider as well.
Okay. Thank you very much. Having a little technical difficulty here. I'm not quite sure why. I apologize. I'm not sure what's going on here. Just enough to cause a little
Patti,
trouble.
do you need me to share?
Yes, would you do that for me? I'm not sure what's going on. It's kind of locked up, Amanda. Thank you.
Give me just a second. I'll get it up.
Okay, thank you.
Mhm.
This technology, it works wonderfully until it doesn't, right?
Okay.
I see that somebody has commented that IT, or no, sorry, it seems like a lot of, you can tell I'm talking about IT. It seems like a lot of public awareness types of education are necessary. I completely agree with that. I think the materials that Lindsay shared are incredible. That would be very helpful to get out in the community.
And I can tell you that we're calling upon our friends to give us not necessarily access to all of their listservs, but to share the information that we've provided, who Laura is, what she is trying to do, as well as the materials that I went over, and a summary of all of the testing recommendations. And we're planning to really hit the ground running with that starting next week.
Wow, that's great. That's great. So if we have any other questions, if you'll raise your hand, Amanda can unmute you so you can ask questions of our experts here. And if you don't know where to raise your hand, if you'll go to the participants tab, you'll see raise hand down at the bottom of the participant tab. So I guess everybody, no questions because you guys were so thorough.
Helen's got a question.
Oh, great. Great.
Jimmy, this is for you. I didn't catch what that abbreviation was. You said for treatment, was it UT or no, US something? Was it for treatment or just, I missed that part.
I'm not sure if maybe DAA, the direct acting antivirals. Is that
No, it was, I think either US something, wasn't it? US.
USPSTF?
Yeah. Mm-hmm.
Yeah, so that's the United States Preventative Services Task Force.
Okay.
They are an organization that really makes kind of consolidated guidance for all the routine health maintenance stuff that should happen. So they're the ones who promote like colon cancer screening should start at 50 years of age or whatever the recommendation is. I don't know, I'm a pediatrician.
Okay.
But along with like the CDC recommendation to do universal screening, USPSTF has also endorsed that.
Okay, thank you.
Yeah.
Did you see the question in the chat, Dr. Carlucci from Lauren? How early can you treat pediatric patients?
Yeah, so Lindsay beat me to it. But yeah, 3 years now. There's been a lot of rapid progress in this space in recent years. It started off at 12 years of age. And really, this has just been a reflection of clinical trial data. I mean, you know, like with any clinical trial, we're seeing it with COVID vaccine now, you know, you start with older age groups where, you know, there's less ethical concerns about enrolling young people in clinical trials. Similarly, you know, we initially had data for 12 and above, and then it was 6 and above, and now they have data down to 3 years of age. The only tricky part about treating a child that age is you have fewer medications to choose from, and obviously 3-year-olds don't swallow pills. So you also have to be sensitive to, you know, how it's dosed and stuff. But, you know, working alongside a clinical pharmacist, because usually if you're going to be treating a child, this is going to happen at a referral center. So you're going to be engaged with a specialist, either an infectious disease doctor or a hepatologist, and they're going to have a clinical pharmacist kind of working alongside them that can help navigate all those issues. So yeah, the short answer is 3 years of age, but but there is a little bit of it's not as easy as going to your pediatrician and getting a prescription.
Yeah, and this is Lindsey. So I would just add that, you know, in addition to wanting to expand to have more Lauras throughout the state, because I think, you know, we had to start somewhere, right? But we've learned a lot in the last 1.5 to 2 years. And so it's really going to be important to expand that. But also what keeps me up at night, honestly, is the pediatric hepatitis C cases, because I feel like we're not really watching them, right? So for what we're doing right now with Laura, we have to, one, identify a hepatitis C positive woman who had a recent live birth, you know, get all that information together, and then try to do outreach to ensure that that infant gets tested, right? And so it's all reliant on first diagnosing mom and then diagnosing baby or testing baby, right? But I wonder about, you know, what about these children who that didn't happen, where we didn't identify mom, and they have had not only an exposure, but they actually did become infected, right? What about them? And so I do wonder about, you know, especially as Dr. Carlucci mentioned, the treatment guidelines changed pretty recently. It used to be 12, now it's 3. So especially in that 3 to 12 age range, you know, what are we doing? And so that is something on my to-do list, right? Is to try to work a program like what we're doing with Laura for that particular population, just to make sure there's awareness and that, you know, they are getting the treatment that they qualify for now.
Yeah, and I would add to that, I mean, and I don't know that we have this data in hepatitis C, but at least in the HIV space, we know that doing index case testing is way higher yield than just like testing people at random, right? So meaning if you have a mom that is known positive, then obviously the newborn needs to be tested, but it's not just the newborn, it's everybody in their household should be tested. And that might include children in that 3 to 12 year window who are treatment eligible, who just didn't get tested because, you know, it just wasn't on providers' radar 3 years ago. So I think not only educating providers about, hey, there's updated guidance on when you could test, but please make sure you're testing the other kids who haven't yet been tested as well.
So I've seen these results on some of the moms. Do we have any idea, Lindsey, how many OBs in Tennessee are testing for this already? Just, you know, as part of their testing, not because it's required, of course.
Yeah, so I mean, we were seeing OBs testing even before the new testing recommendations came out, right? Which is great, especially some of our champions who, you know who you are. But I will say that with the new testing recommendations coming out, we really wanted to try to figure out what that looks like. And so we have developed a survey that asks about that. And so when we do this blast education, we are going to send the survey too, because we want to try to elicit that feedback. You know, are you currently testing? Do you plan to? If you're not, why not? And just really try to get a sense for what's going on statewide and not just in Eastern Tennessee.
Mm-hmm. That's great. All right, this is great discussion. Any other questions from anybody?
Well, I have a question. I guess in the spirit of competitiveness, does it irk the folks at Tennessee Department of Health to know that Kentucky has already endorsed universal screening like 2 years ago or maybe longer?
Yes. I will say, you know, it's also like on my bucket list, honestly, to do a project with Kentucky in this space, because I just feel like we are so disproportionately impacted by not only hepatitis C, but, you know, perinatal exposures, and just, we need to join forces and try to do some kind of a QI project, if you will, with both states to try to, you know, really improve what we're seeing.
Yeah, and I can say Indiana is not there yet either. And so it's, Tennessee's not alone. But I do think that, it's one thing to advocate, to OBs, it's another for, a state to endorse it, and better yet, for it to be federally endorsed, which now, CDC has done. But my opinion.
And I think that's partially thanks to our former
Right.
champion, Dr. Carolyn Wester, who used to be my boss, but left us to be the division director for the Division of Viral Hepatitis at CDC, and has just been knocking down doors and making tons of strides. And I think we're seeing the benefit of that from our end.
Awesome.
It's like Helen has another question, so.
Great.
Okay. Helen, you should be able to talk.
Sorry, I didn't unmute. Okay, I was just, what I'm going to ask is about breastfeeding, and are there any studies related to with hepatitis and breastfeeding? I know they've done it with HIV, but I'm just curious.
Yes. No, I'm glad you brought that up. I should have put that in my presentation. It is safe for hepatitis C positive moms to breastfeed. And that is a message that I think we don't clearly communicate to these moms. Because I can't count, how many, patients show up in infectious disease clinic, for example, at, 2-3 months of age or whatever. And you ask, how's, not only Hep C related things, but, how's it going? Feeding, growing, how are you feeding your baby? And they've not breastfed, and you ask, well, why? And it's because mom was either says she was told or at least thought that she shouldn't because of risk for breast milk transmission, which really the risk is I don't want to say zero, but it's negligible. There is a potential if mom has cracked or bleeding nipples. That's a scenario where we would tell mom abstain, just pump and pump and dump to keep your supply, and supplement with formula until that heals up. But outside of that scenario, it's safe for Hep C positive moms to breastfeed their babies.
Yeah, the last time I checked, there's not been a documented case of breast milk transmission of hepatitis C in the United States, which, I mean, you got to be reassured by that, right?
Mm-hmm. Mm-hmm. All right, great conversation. Any other questions before we talk about podcasts? Well, our experts have given us a lot to think about, that's for sure. Thank you both very much. We enjoyed that. All right, so podcasts. Amanda mentioned this at the beginning of the workshop, so I'm just going to hit it one more time. Episode 9 of the Healthy Mom, Healthy Baby Tennessee TIPQC podcast is on this topic. It's Dr. Carlucci and Dr. Morad. So if you missed something or you want to listen to it again, I would definitely go to episode 9. You can access all the podcasts from the TIPQC website. You can also access it from a podcast app, which I'm proud to say that even I can do, since I have no social media skills, but I can do podcasts.
Yeah, we're on all podcasting services, Amazon.
Even I can find it, Amanda.
Spotify, all those. Also,
Right.
if you have a subject that you're just dying to learn more about, or have somebody that you really admire working in the perinatal space that you want to hear, please let me know, because we are hoping to have an episode every week, and that's 52 episodes a year. So definitely need lots of suggestions to help us keep going. So feel
All
free to
right,
chat those
so
in.
we're going to finish up a little bit early here, so that gives you time to stretch, but it does not give you time to not come back to closing ceremonies, okay? We have some exciting information in the closing ceremonies, so get up, get another glass of water, go to the ladies' room, the gentleman's room, whatever you need to do, but come back at 4:30, because we're going to not only talk about the topics that you all voted for most, we're going to hear about the poster session winners, all kinds of good information from 4:30 to 5. So we will see you on the main stage at 4:30. Have a great afternoon. Thank you.